good to have stuff to catch up on and be around to catch up on it. So another minute or so. We have about 25 participants. Usually we get to about 30 by 12:02, and I usually introduce then, and you'll peak at about 12:08, 09. Jenna, who is the goodies for?
For my fellow chiefs,
All right,
got to keep them happy and, not so healthy.
Keep business up and can make them happy and have future business. I like it.
All right.
I like it a lot.
Although if you happen to mobilize over here, there's still some donuts.
Oh my. I think I'll keep that in mind just in case I need an afternoon sugar rush.
Yeah.
We're about at a good point here. So welcome everyone to the Roy Benke Internal Medicine Grand Rounds on a Thursday. So it's great to be back with you. Again, thank you for all the well wishes after the car accident, and it's glad to be in one piece and glad to be here with you all. And I made it out to Boston last week for the MACP induction. It was a lot of fun. What a great moment for our Department of Internal Medicine. I dropped USF everywhere I could. So USFIM, and what nobody asks these days when I say USF, they don't say, where's that at? Everybody knows it's in Tampa. What a difference compared to about 10 to 12 years ago. So a great week ceremony out there and conference out there, and just very, very excited for discussed with folks what we're doing here, and lots of folks stating exciting times in Tampa, and I agree. One of the many things that we were recognized in Boston for was our patient safety quality improvement program. We're well known as one of the first in the nation, thanks to the work of Dr. Alexander Rice and Elizabeth Melzer to continue to make this program to be the best in the nation. It really is. We are visited by Ivy League entities to see the quality of our program. We're asked by others to collaborate on building curriculums. And a lot of that has to do with just the continual process of getting all-stars to be our patient safety chief residents. I kid Dr. Rice and Dr. Melzer that the interview process starts now somewhere around 8th grade with initial interest, and we track high school progress through college with maybe a VVC in college, and then obviously, keep an eye on them even closer through medical school. But today we have two of the latest in the litany of outstanding chief residents in patient safety and quality improvement. And I want to really point out that our program also has not only been a VA program, I always call this is a USF program, and evidence of that was with the effect that it's had on Tampa General, with not only the fellows that have been at Tampa General, such as Dr. Carlos Bertrand, who's now a GI person, a GI fellow. Sorry, a little concussion from the car accident still. Revati Reddy, who also did an outstanding job and became a cardiologist, and she's finishing her training in New Mexico, I believe, this year. So the impact has been beyond facility. It has impacted Tampa General, and a lot of their patient safety quality improvement work has been in conjunction with things that have happened in the VA, and likewise has spilled in a lot of things that the Moffitt Cancer Center does. That's what I'm really proudest of this program, is what it continues to do at the USF Department of Internal Medicine level and really at all the affiliates with USF. So our two current chief residents, first is Jenna BILODEAU-GANDRE, and she is a graduate of the University of Florida for her undergrad, then spent some time here at USF for her master's before going to the Florida International University for medical school. I got to meet her and her husband, Jason, who is now a primary care physician at the VA. I met them on their interview day way back in 2019, back right before the pandemic started. And Jenna has done an outstanding job in our residency, numerous quality improvement projects, and is going to be a cardiologist in Mayo Jacksonville coming up this year. Very, very exciting. Juan ENCISO, very much USF background in college and master's. Then went to Lake Erie College of Osteopathic Medicine, came for internal medicine residency training here, and has done as splendid a job as Jenna with numerous patient safety quality improvement projects, as well becoming a cardiologist. Yes, we tend to attract a lot of cardiologists, as you've heard, with this patient safety and quality improvement, but our residency is very cardiologic philic. In fact, we have enough people who matched 12 that we could do a 12 lead EKG based on all of the patient safety chief residents and residents who matched in a cardiology. That's my goal, is that they all line up as a 12 lead EKG before they all leave the Tampa area. So we're looking forward to their update today, enhancing medical education through quality improvement and patient safety. And it's a pleasure to introduce the Killer Jays, Jenna and Juan. So take it away, guys.
Thank you.
Awesome. I mean, great introduction. Thank you so much, guys. So the theme of our presentation today is going to be enhancing medical education through quality improvement and patient safety. We have no financial conflicts of interest to disclose.
Although sometimes we wish we did.
So our objectives for today, our goal and objectives for this presentation will be to focus on quality improvement and patient safety. We will begin with an overview of the key concepts that's around quality improvement, delve into some of the history of what started the focus of quality control and safety frameworks, barriers, and the roles of healthcare professionals and patient safety. We will learn about the significance of quality improvement and patient safety initiatives through medical education. We will aim to offer you some compelling evidence demonstrating the crucial role of integrating quality improvement practices into our trainee medical curriculums. We will highlight the success stories of case studies and data that support the importance of early implementation of quality improvement and patient safety practices. And lastly, we will discuss how implementing these practices helps foster better process improvement, patient safety, and how they impact scholarly work and publications. Next, we'll discuss some of the quality improvement and patient safety education current activities here within our own USF. Our team is leading current initiatives that educate medical students, residents, and fellows in internal medicine about quality improvement and patient safety frameworks. We'll provide you with some examples of the quality improvement and patient safety initiatives led by USF internal medicine residents. And lastly, we will provide you with some information of what to do, of what we do as our roles as chief residents in quality improvement and patient safety. We'll present some of the initiatives that we deployed and currently underway, including our ECOS pathway, and some of the impacts that we had with our QI projects, some of the impacts, some of the lessons, and some of our future directions within our projects. And hopefully we'll allow enough time for some conclusion and Q&A. All right, so getting to it. So introduction to quality improvement and patient safety. So we'd like to engage the audience first and try to get you guys to, I'll be a little participant with this conversation, right? We can use the hands up feature and we like to have your involvement. And the question that we bring to you guys is, who in the audience has had experience with quality improvement or patient safety? So I see some hands going up already. That's good. So then we like to ask next is, who has had dedicated quality improvement in patient safety teaching and training? You can still keep your hands up. That still applies to you. That's good. Awesome. Awesome.
Yeah.
Then we can use the chat waterfall feature so you guys can write your comment and we'll tell you when to release it. So we like to ask the question to the audience is, when you come up, when we ask you, why does quality improvement and patient safety matter in healthcare? You can just write a comment, and then in about 10 seconds, we'll ask you to just enter or send it, and we'll see what replies we get. So asking again, why does quality improvement and patient safety matter in healthcare? See what we get in about maybe 10 seconds or so, like TikTok.
We've got one. Nothing else matters. I agree.
Nothing else matters.
Well, that's the end of this conversation.
Right.
Thank you so much. We've got prevent errors to patients.
Yeah, we can get some, you can just start sending them right now, see what we get.
Yeah. Yeah. Making our system safer and more efficient. We are imperfect humans. We're going to talk about that too.
Excellent. Those some great responses for sure.
Yeah. Thanks for participating.
Definitely. So we like to ask then, just starting with some of the definitions so that, our audience can be more involved in. So what is quality improvement? We start thinking of quality improvement. So I like to imagine it as, or letting you have an imagination of, think about it, a perfect recipe, right? You try to find the different ingredients and techniques. We keep what works in our recipe, and we discard or adjust things that don't. We try to adjust this process until our recipe is delicious and our dish is good to go. Quality improvement in healthcare works in a similar process, but the focus is on patient care. Healthcare teams continuously evaluate how they diagnose, how they treat and interact with patients, and look for ways to improve these processes. Quality improvement frameworks is used to improve processes and systems systematically. That's the point of quality. But why is quality important? Why is quality improvement vital? It's vital because it ensures safety. This helps ensure that care is delivered without causing harm. The ultimate goal is to achieve a system that leads to zero harm. It leads to improved outcomes. Our goal is to provide patients with better healthcare outcomes. Patients come into our healthcare system to obtain services that will ultimately improve their health, and their goal is to try our best to make that a possibility. And we enhance patient efficiency, reduces waste. We can reduce waste and optimize our resources, which can also help with cost. When we think of cost, it can take multiple meanings, right? It can mean monetary value, so the actual healthcare cost itself, overhead cost, cost of staff, cost of a length of stay, or it can be time. It's a reduction in the time this patient stays inpatient, prolonged length of stay, or even time for us providers and practitioners of how much work we can get done or versus how much work we have to take home to finish. It enhances patient experiences. This focus is on improving patient care and patient experience, ensuring that they're treated with respect, that they're treated with dignity, there's compassion, and we make accommodations to improve our patients' inclusivity. We try to address our physical barriers, our linguistic barriers, and our socioeconomic barriers. So dividing healthcare qualities is into really just 6 key dimensions, and this was defined by the Institute of Medicine, the IOM. Each dimension of healthcare quality, as defined, is basically centered to keep the patient in mind and how we can best deliver the best care possible for each patient. Some of these dimensions of quality involve safety, right? For example, we've implemented new barcodes for medication administration to make sure that the correct medication gets given to the correct patient, the correct dosage at the correct time. We work on its effectiveness. For example, a clinic may use evidence-based guidelines and practices to treat hypertension. This is to ensure that patients receive the appropriate interventions, and these interventions are foolproof through rigorous research. This approach is to help better control blood pressure, reduce the risk of heart attack or stroke. It's patient-centered, right? Healthcare providers, we use multiple communication options, including in-person visits. We accommodate with telehealth appointments or secure messaging. This allows patients to choose how they want to engage with their healthcare providers and to meet their needs, and makes the experience more responsive to each individual based on their preferences. Is it timely, right? This is, for example, the things that come to mind is an emergency room department recognizes that there's an important triage processing to reduce times. They implement a fast track system to treat the less critical, and patients receive care more quickly and improve outcomes and reduce stress and discomfort. Is the efficiency of it. Hospital develops a centralized scheduling system for all outpatient services to optimize resources to prevent overlap, to reduce idle time. And this is to improve the process and make it smoother, safer, and cost-effective. And is it equitable? Community healthcare centers, for example, can provide a translation service to target this culturally diverse community. By ensuring language and culture are not just barriers of care. The center can work toward delivering equitable healthcare where patients have the same needs met across all high-quality standards and backgrounds. So then we ask is, what is patient safety? Now that we've discussed some of the terminology for quality improvement, let's delve into it. So the example that I like to start off with is, imagine you're sending your child to school. You entrust that the school will keep them safe and keep them safe from harm, that they will return to you in the same health condition, or if not better, they learn something at school, right? Patient safety in healthcare works in a similar principle. When you visit a hospital, when you visit a clinic, when you visit any healthcare touch point or setting, you entrust that the care that you will receive will not cause you harm. In fact, it would hopefully improve your conditions. So according to the World Health Organization, the definition of patient safety aims to create culture, processes, behaviors, and environments that reduce patient risk and harm. So why is this important? Patient safety prevents harm. Just like we use seatbelts to prevent injuries when we have car crashes, healthcare providers follow specific procedures to prevent infection risks, to prevent mistakes, or to prevent other complications. It builds trust, knowing that the healthcare system is doing everything it can to keep you safe. It helps build trust between the patient and the healthcare system and the provider. And it aims to improve healthcare outcomes, safe healthcare practices to increase the likelihood of successful treatments and reduce the risk of developing issues or adverse events. So when we talk about healthcare and healthcare professionals involved in quality improvement, this is just a small sample list of the professions that interact and come to mind. We have physicians, nursing staff, we have pharmacists, we have our therapists, our occupational physical speech.
Leave your message for 941725892.
We have an open mic there, sorry. We have an health informatics, and we have our social work. But overall is the healthcare professionals that are really involved in reality, really all healthcare professionals have an important role to play in the improvement of healthcare and quality improvement and patient safety. Through their active participation, their teamwork, and their leadership, they become integral part of pointing out errors and making adjustments to improve this recipe like we talked about. So how do we ensure patient safety? It really comes down to our training, right? Healthcare workers receive training to perform procedures safely, much like how pilots do training simulations so they can ensure they can fly safely. They do it through technology. Medical facilities implement the electronic medical record. It helps us to have automated alerts. It helps us to track patients. It helps us to alert doctors to potential issues. This is similar to when a GPS warns you of an upcoming roadblock or traffic jam and you try to adjust and divert. Technology will have one of the biggest impacts, I believe, coming up in future patient safety and quality improvement practices. As we become more aware of and start utilizing more of the machine learning and deep medicine with artificial intelligence or AI, is now looking to optimize how we interact with quality improvement and patient safety, and this being one of the hot topics that's developing and coming down in the pipeline. How we report and learn from mistakes. When errors happen, they are carefully analyzed, and this is obviously without trying to place any blame, to understand what went wrong and what we can do to prevent it from happening again. And lastly, some examples for guidelines and protocols. Hospitals follow strict guidelines, like using a checklist before surgery, similar to a pilot's pre-check flight, to ensure that nothing important is overlooked. These are just some of the examples how we can do it. But now that we've taken you through some of the fundamentals of quality improvement and patient safety, we have reviewed some of the ways that they can ensure safety as well. But now we have to discuss some of the challenges that make quality improvement and patient safety practices difficult to implement in real world practice. There's cultural barriers, right? There's healthcare professionals may resist to change to establish practices. This is even in the face of new evidence that new procedures that improve patient safety and quality of care. One of the examples just alluded to prior was our timeout, right? Our checklists. Surgeons initially resisted adopting new surgical checklists, despite it being shown that it reduced complications. They felt it was unnecessary or slowed them down. Some of the barriers, financial, of course, insufficient funding can restrict the ability of healthcare facilities to invest in new technologies or staff training or improve facilities or improve other ancillary services that can help facilitate and enhance patient safety. There's a human resource component. Staff shortages, insufficient staffing levels can lead to overlooked or overworked employees, increasing the likelihood of mistakes. One example could be nursing staff at a nursing home can have a high patient to nurse ratio, where nurses don't spend adequate time with each patient and potentially can lead to a missing early diagnosis of deterioration. Our systemic barriers, our fragmented healthcare system. A lack of coordination across different levels of care can lead to gaps in patient safety and quality improvement. This is often emphasized here at the VA, where we try to ensure that our hospital discharges are linked to the primary care providers to try to make sure we enclose that gap in healthcare practice. Some other barriers that we want to include here are regulatory and policy barriers, right? Navigating the complex landscape of healthcare regulations can divert resources and attention away from patient safety initiatives. There's the technological barriers, right? Poorly designed or outdated information technology systems can hinder the effective collection of data, sharing of data, and analytical data analysis critical for quality improvement. There's educational barriers where there's lack of training. Healthcare professionals may not receive adequate training on the latest evidence-based practices for patient safety or quality improvement. And one that we like to really focus on is our psychological barriers. And this is one of the ones that, we as healthcare providers, practitioners tend to work or we may be reluctant to report errors or unsafe conditions due to fear of punishment or retaliation.
All right. So now that we've kind of given you a background into what's going on and why, patient safety and what quality improvement really does and the barriers for implementing it, we're going to talk about the role of it in medical education initiatives. The first thing, I would be remiss, everyone brings this up every time we talk about it, but of course it kind of spearheaded in 1999. To Err is Human actually got leaked to the press. There was a couple of different studies that they had actually done that looked retrospectively at people who had died from hospitalizations. And based off it, they actually went through and determined whether or not a person had actually had a medical error during that time. And based off that, they estimated that almost 44,000 to 98,000 people were dying from medical errors every year. And so, of course, the press got a hold of that. It became a big problem because essentially everyone's like, well, if you're going to the hospital to get safe care, can you give quality care if it's not safe? It got updated, and I realized now it got truncated, but in 2013, BMJ actually updated the numbers. They looked at death rates, and there was a death rate of 0.6 to 1.13%. And unfortunately, that equated to 210,000 to 400,000 deaths each year in the United States alone from medical errors. With all of that being said, it's difficult because, how we estimate all of that is out of scope for this topic. But when we talk about the different ways that we investigate it, we might be underreporting, we might be underestimating those numbers because a lot of times they're only considering people who are on the inpatient side. But we know medical errors occur in pharmacy, they occur in the outpatient clinics, they occur with images. So we know that might actually be higher. And actually, the Harvard Medical Practice data just put out a new paper in New England Journal of Medicine late last year, where they had estimated that almost 15.1 to 47 adverse events occurred per 100 admissions. So we think that number is actually pretty big. And all of that's to say that before COVID, it was actually the number 3 cause of death based off estimate. And that's, kind of dependent on which paper and how they estimated all of that. But it is a big deal. And that's kind of what we're trying to get at. And so when we talk about quality improvement education, it's crucial for training healthcare professionals to deliver safe and high quality care. And that's because of the fact that these are going to be your frontline workers, the people who see this process day in and day out, who need to be cognizant of how to actually evaluate and study those events to understand what's going into them so that way they can better the system that they're in. it's in like we have to integrate QI principles into medical school and residency curriculums to equip trainees with the skills to lead improvement efforts and achieve better patient outcomes. And a lot of this, like, there was a comment in the chat about what defines the best. And so we consider things like quality measures. We'll say the measurements aren't exactly amazing. When we come to how we define some of those terms, it really kind of shoots us in the foot when we get like down to it. But it really should help define the best. It should help us figure out how we can provide efficient, safe, like effective healthcare. So when we talk about it, the AAMC actually does recommend integrating QI and patient safety into medical education for undergraduates. So our medical students are recommended to do some of these things, but it's not necessarily required by LCME. When we went through it, we were trying to figure out like if there's a spelled out process for like how to determine if there's getting QI and patient safety education. Unfortunately, we don't see a lot of that actually spelled out. And so it's up to the medical school as to how they define it. And the only measure or the mention of QI that LCME actually mentions is that the medical schools themselves have to go through a QI process to try to improve and show that they're doing better for meeting the requirements for their continued, accreditation, but that's about it. And then when we jump to ACGME, there's a huge difference. So when we go to like what's required, the common recommendations and the things that we need to follow, we do need to teach about patient safety. We do have to kind of encourage culture of safety. We are supposed to have them demonstrate like an understanding of how to do a QI project. And the thing about it is that we're all really good at research. We learn how to like investigate. We learn how to actually focus on whether it's a good paper or a bad paper. We focus on hypothesis generation and then testing that. But QI is very different. QI requires that we actually investigate the problem thoroughly before we come up with a process for like trying to fix it. We don't create a hypothesis and then test it because we might be messing up that system even more because we failed to recognize what the root cause of it was. And so having that integrated into our trainees like education is really important because it sets the it essentially sets the baseline for what the rest of their like career is going to look like. So this is probably you. You're a little suspicious. You're like, hey, this is a talk about like enhancing medical education with all of these things, but why should I care? Which is okay, because I recognize that with the barriers that Juan had talked about before, a significant amount of them are because of time and education and resources. We have people who are going through this training and actually understanding it and putting forth that time. But when it comes down to it, and we're talking about how like research is kind of like provided in terms of grants and things like that, the impact of quality improvement work is really hard to kind of show, and it's hard to scale. You can do a lot of different studies. You may have a really great project that you can actually implement on your system level. But by the time it needs to be scaled to the next facility, that facility might follow a different standardized protocol. They might go through different things. And so you really do need to reinvestigate the problem and how it would be integrated into those things. So I'm going to argue that by doing and having this education for our trainees, we really do improve outcomes. And I will preface this by saying that a lot of our data is very much subjective. It's going to be based off trainee experience, trainee surveys, because the longer outcome measures that we're kind of looking for are behavioral changes and system changes, which are difficult to measure in a short time scale. So when we talk about these different papers and stuff like that, to show that this is a thing, you'd have to do more longitudinal studies to really show that this is going to continue to impact it. But I will say from anecdotally, we know that our trainees actually continue on and do a lot of quality improvement and patient safety work, as evidenced even in the chat. So the low-hanging fruit is when you integrate these things into training for the medical students and the residents, they do better on milestones. So, when we get down to the problem-based learning, this study by Pohl and al., they had actually showed that you could increase those milestones up to a 4.6, which is on a scale of 1 to 5, with the higher being closer to being able to achieve independent practice. So, if you had a longitudinal QI curriculum that was built into your education, you actually did better in terms of your milestones. This showed that if you had a longitudinal curriculum that you built into your ambulatory block, so this is for all of those X+Y, clinic blocks, that 75% of the residents who participated in a 3-year program modified their behaviors as physicians. And what that means is that they understand the system a little bit better. So number one, they can navigate it a little bit better because they know what vulnerabilities might exist. And number two, they're more likely to create more patient-centered, individualized care plans because of the fact that they know which barriers they might have to go through. Then when you consider it, 72% of residents learn skills that are useful in their practice. I mean, if you investigate a problem and you happen to realize that there's certain steps that need to be done before that happens, even if they're wasteful, then you might be more efficient in getting those things done so that way your patient can get more effective and quicker care. In this one, they actually did an investigation into Kirkpatrick levels of evaluation. So this is kind of the levels of at which they learned from quality improvement. And the higher levels, which are 3 and 4, which is, I did behavioral change and I had a systemic change, and there was a patient benefit. A lot of the studies have actually been trying to increase that evaluation to see if that's something that's happened. We actually do a lot of this in things like our patient event reporting, because you can track that as an outcome measure to see if people are understanding of patient safety curriculums and stuff. But when they looked at behavioral changes and they actually looked at level 3 for a longitudinal QI curriculum, there was sustained positive behaviors and subsequent QI engagement in their future years. And then when we get down to it, if you have a longitudinal QI curriculum for about 3 years, do you have people who will actually implement changes and help with the system process? And in this, they actually showed that 90% of them declared to have implemented actions. And this is just based off actually fixing a process or fixing a problem that they ran into, with 50% of them being fully implemented. And that was within a year of them actually doing the longitudinal curriculum. And so there's still some room, obviously, between what people perceive as having been done and what fully implemented projects kind of occurred. But that is a building block that you can continue, because if you can have people like HR champions or people that can help remove barriers for you, that number might go up. And then we talk about improved culture of safety actually leads to better health outcomes. So this was a paper in JACS that actually showed that if you had better safety culture scores, so that's a % positive, meaning that you felt safe, you were psychologically safe, you were able to put in event reports, you felt heard, you had lower surgical site infections for colon surgeries. It also improves patient satisfaction. So if you have a better score in terms of your safety culture, your patients actually felt like they got better care. And so there are a lot of studies that show this. And then when we talk about it, we're not going to go into the whole thing of this paper, but this paper actually showed that if you had patient falls, and you were to put together an interdisciplinary team where they could create more knowledge of the system, they could help identify barriers, and they could help with creating innovative ways to decrease fall risk, that they did better, and they actually observed fewer falls on those interdisciplinary teams than people who did it individually. So you're more likely to actually have better quality improvement and better interdisciplinary teamwork if you were to have QI together rather than separate. And then with this, this is the longitudinal curriculum, and it helps with like in terms of scholarly activity. So they actually did like 18 QI projects in the span of this 3 years with 69 abstracts and posters that they actually created based off all of these individual QI projects. And it didn't require much. There were actually only 2 mentors in this paper to help with all of these like residents, which was, I think they were 54 residents. They spent 50 hours total on mentoring them through all of these like different QI projects, and with it, it increased scholarly activity. Here's some additional examples. So, in terms of interdisciplinary morbidity and mortality, you actually had better outcomes and you had more involvement in people who may not even be clinical. They actually had environmental services and people come in to help discuss like the safety issues that resulted in some of these like adverse events. And because of it, they actually scored better as well on their like milestones from this like paper. So all of this is to say that if we were to integrate this into training and get our medical students and our residents more involved in it, they're going to have better interdisciplinary teamwork. They're going to have better care. Their patient satisfaction scores should go up. They're going to do better on their like milestones. And so there's a bunch of different reasons why this matters and why we need to continue to work on our like education components. And so again, the barriers that we run into is, there's no standardized like QI and patient safety curriculum. And that's only because of the fact that individual trainings, like, areas and different like programs, they might not have the QI and patient safety training that most of us may have. They may not have the time. Their call schedules are different. They may not even have X+Y. They might lack dedicated teaching time for all of these topics. It's dependent on trainee familiarity with their healthcare systems, because maybe they recognize that there's a problem, but they don't know how to investigate it because they're not as familiar with the system. There's competing trainee priorities because, as Dr. Lizama alluded to, a lot of us are going into cardiology. So, do you emphasize the time that you spend with your subspecialty mentors versus doing QI projects and things like that? And how do you like mesh the two together to make it so that way you can be successful no matter what? And then just the number of faculty trained in QI and patient safety. And so, the big picture is that trainees who become involved in QI and patient safety go into early careers, fostering a culture and standard for best practice and process improvement.
Awesome. So going to highlight with the section 3. So what are some of the, we're going to highlight some of the many innovative initiatives here with University of South Florida. While the majority of this presentation will focus on some of the initiatives provided through the VA and the inpatient medicine portion here with QI, I want to just briefly highlight that there's also some amazing QI initiatives that take place at Tampa General and at our multiple continuity clinics sites like Morsani and Health Park. So some of as we've discussed, so quality improvement in education is essential for trainee education. USF, in collaboration with the James A. Haley, is not only emphasizing the importance of quality improvement in residency and education, but is also taking a unique step. We're focusing on early implementation of patient safety practices through curriculum specifically tailored to our medical students. As with medical student education, our medical students in their first and second years receive specific didactics that serve as a foundation for their introduction to patient safety practices and terminology and quality improvement principles. Third-year medical students can participate in our interprofessional patient safety curriculums. A little bit more of that detail to come is going to be our IPSIs. For those medical students that are interested in internal medicine or passionate about quality improvement in patient safety, there's our VA hospitalist rotation in their 4th year that offers a unique opportunity. This rotation allows for dedicated half days that provide hands-on experience and focus on learning these topics and principles. And really is to highlight other things that we do here at USF is the importance of continuous exposure and continuous learning. Is why our students receive additional patient safety activities throughout their medical school curriculum. These activities are integrated into their doctoring, provide constant introduction to patient-centered safe practices and process improvement. So with regards to IPSI, so our interprofessional patient safety education curriculum, it consists of a 2-hour session during their 3rd year of medical school at the time of their internal medicine rotation here with us at the James A. Haley. This curriculum is centered on teaching them patient safety introduction. So we teach them about the Swiss cheese model of system failure, differentiate between system solutions and implementing the hierarchy of actions, describe some patient safety methods like root cause analysis and process mapping. We focus on human factors engineering, how human factors influence the interface between healthcare practices or between providers and their practice. We've recognized some vulnerabilities in between these systems, and we classify our system problems based on the hierarchy of actions. We do a medication tracer. We analyze different steps involved that impact patient safety and quality of care. We relate these system vulnerabilities in an attempt to find some safeguards against them and teach our trainees to be wary of medication changes or be part of the process that leads to system improvement, that they themselves can be part of the process that helps promote quality improvement in patient safety. And lastly, we do environment of care, which is our simulations. We use a standardized patient or we use a mannequin, and we do process improvement, and we try to find the hazards and the imperfections that can be found in a patient room. We propose some solution to all these vulnerabilities, and we incorporate direct feedback regarding these environmental hazards. So some of the approaches for enhancing quality for our residents. So our efforts to improve exposure for patient safety and quality improvement methodologies also extend to our residents. Here at the James A. Haley, we're responsible for providing some educational support to our residents in some of these following ways. We do our CB Safe, which is our case-based system analysis and vulnerabilities. This is our revamped new version of our case-based conference series, where we use actual patient cases and allow our trainees to independently analyze and identify some vulnerabilities in a healthcare system. And we'll go more of this in detail. We do clinic group mock RCAs. We use Friday didactic conferences as interactive sessions where we conduct mock root cause analysis and with our internal medicine clinic groups to get a deeper understanding of some of the root causes and medical errors, and we encourage resident participation. We do our quality with, this is more of a discussion that will be for future grand rounds, but just to mention it briefly, we just provide some training on patient safety tools and methodologies for categorical and prelim PGY1 trainees. We do our presentations with subspecialty fellow QI workshops, where we provide workshops in quality improvement to our fellows. These QI workshops include didactic courses that help them inform our fellows about what constitutes as research versus quality improvement and some of the resources for conducting and publishing quality improvement projects. We have our EQUIPS pathway, which is a new quality improvement pathway for our internal medicine residents, which we'll touch base in a little bit. And we have our ambulatory clinic-based didactics as our outpatient medicine continuity clinics are the cornerstone of our clinic didactics training here at the University of South Florida. Our Friday didactic blocks provide quality improvement in patient safety training and encourage our residents to work on projects relating to their continuity clinics and how we can improve those clinics. And lastly, we'll just touch base on some resident-led initiatives, some of the resident prior QI projects that they've started or they've been involved with, and how these can help and how we've helped contribute to their project development. So going over CB Safe, which is our case-based system analysis and vulnerabilities. So this stems off from morbidity mortality conferences, or M&Ms, which is an ACGME mandated educational series. Any residency institution program attempts to practice some of these, and the potential for learning for medical errors, complications, or anticipated outcomes is immense. We provide that it's provided that the focus is on education instead of blame. CB Safe breaks this down and takes it a step further, where we focus on identifying the areas of improvement. So medical cases are broken down and analyzed to their granular level. We provide some necessary timeline of the events, along with some of the data, imaging, or labs. We make up that these have to be pertinent, and we allow for discussion, and we limit as much of the identifiers with regards to personnel involvement or those that were directly involved in care. The focus is that the conference allows for trainees to review the cases as a first-person point of view. As we take them through the case, they're asked to elaborate for possible causes that led to the errors of the information presented. Trainees are asked to identify and focus on system communication and human factors or cognitive errors and biases. And these contributing factors are discussed with the focus taking on finding the appropriate root causes for these errors. Once our root causes are identified or analyzed, we collaborate with the audience and try to brainstorm solutions right then and there to change and improve patient outcomes. This often becomes a multidisciplinary approach in collaboration with other specialties or other peers or staff. And we believe this is crucial in part of improving patient outcomes. And really overall, CBSAFE just really fosters an environment where peers can discuss potential root causes and implement some of these solutions with supervision or assistance from senior faculty and attendings and presence. Some of the recent changes that we made through CBSAFE, we're going to talk about here. So some of the processes, we've done some process improvement with inpatient medication prescription practices. Our case conferences have facilitated by CBSAFE have not only led to improvements in prescription practices, inpatient services, or implementation of additional barriers when processing medications, but have also underscored the importance of a multidisciplinary approach. In specific cases, our representatives, we have representatives from medicine, we have representatives from inpatient pharmacy and nursing, and they each contribute their unique insight or their unique expertise to these analyses in these cases. In this instance at the VA, this highlights some of the VA as a testament to the value of our interdisciplinary team approach and how us working together can really drive process improvement. So we have some subsequent cases that we highlighted here, and it shows the transformative nature of analyzing medical cases through this outcome and this approach. We have reformed, and we're in the process of reforming our stat imaging result notification processes, and CBSAFE has been an instrumental part of it, making a significant stride to improving our process by analyzing system and communication vulnerabilities, addressing alarm fatigue, optimizing closed loop communication, and how we optimize how lab results, such as those from an ABG, can be improved to reduce redundancy and values or improve the ease of utilization. Some of the systems, our CBSAFE system, focuses on human factors and cognitive errors and biases. It has been instrumental in addressing some of these deficiencies in knowledge, some of these deficiencies in experience or decision-making pathways. Through CBSAFE, we identified anchoring and confirmation biases, and something that we've coined ourselves called as the night shift bias, which are failures of patient ownership during the night services. We attempt to address these biases by highlighting some of the key issues that we face together, and hopefully devise some solutions to improve patient safety outcomes. Next, we want to talk about the EQIPS pathway. So EQIPS stands for Executive Quality Improvement and Patient Safety Pathway. And this is something we've been developing in collaboration with our QI and patient safety mentors. So the EQIPS pathway is a track that is designed to provide internal medicine residents with early hands-on exposure and experience in quality improvement and patient safety, which I think it sets us as a privilege. It sets us apart from other different programs. Similar to the models that Jenna talked about with Tendler and their group, this track provides PGY2 residents with the ability to incorporate more of a longitudinal quality improvement project and training into their year by blocking off 2 half-days of their continuity clinic block. And we dedicate these dedicated to didactics and hands-on training, quality improvement, and patient safety. This track will allow residents to work on longitudinal QI projects using the DMAIC framework, and while under the mentorship and guidance of PGY4 chief residents to assist in either in their current quality improvement projects or even help develop one of their own. This track also provides PGY2s with the opportunity to obtain Lean Six Sigma white belt training, learn about proactive risk assessment, and effectively participate in root cause analyses and processes, and learn more about more of these topics. And lastly, this track will be utilized to try to help us provide a transitional pathway for those PGY3 residents that are looking to become now PGY4 chief residents. And as mentioned, we want to provide some of the presentations and workshops that we've done with our fellows. In this academic year, we've worked alongside our GI rheumatology fellows, and we've given them the opportunity and background and some history with regards to patient safety and quality improvement. We've discussed the differences between quality improvement versus research. This is regarding IRB, steps, publications, and presentations. Regarding quality improvement projects and improvement in outcomes being published in journals or at national conferences. We've introduced some of the introduction to some of the settings for how to establish a QI project and some of the methodologies that are required to start a successful QI project. Talk about SMART aim. A project has to be specific, has to be measurable, achievable, and relevant and time bound. And lastly, we provide some resources and references to help them, our fellows, with progressing their QI projects or starting their own, or if we just, sometimes it's just communication and finding the right source or connection to get the project started. And lastly, I would just mention briefly some of the QI initiatives. This is by no means a comprehensive list, but just to mention some of the great quality improvement projects that some of the residents have participated in the past years, and these have been mostly through our VA core rotation. We've worked on add-on labs and optimizing add-on lab testing, standardizing our thyroid ultrasound reporting protocol, improving our DKA protocol, and enhancing our paracentesis thoracentesis processes. Has been involved in the PPI project, which was focused on reducing the unnecessary use of PPIs. We've also had improvement in standardizing resident handoff during their shift changes, and we've worked on providing with the STRIDE program, ongoing mobility for the hospitalized patients. We've worked on hyperkalemia order sets and paging, forward paging systems, and some other projects, including reducing the telemetry overuse. Again, just to highlight a few, but these are just great projects that have led to significant process improvement here at the James A. Haley.
So all of that is to say, like Dr. Lizama said, we are very much known for this. We actually have a very innovative curriculum. We've done a lot, and there's still more that we can do, which is awesome. So let's talk about what we are. When we talk about like the chief resident in quality and patient safety, we actually are a national chief residency where we actually go through NCPS. We have our own EPAs that we are supposed to learn from in terms of what is an HRO, how can we integrate those principles into creating like quality improvement projects to better our institution. For us, we actually do a lot more because we do obtain our green belt training as well as Juan and I are both certified black belts at this point. So we're expected to be, an expert in quality improvement and patient safety by the end of this year. And so there's a whole like pathway to do that through like a national kind of framework and things that we actually do. And so, let's talk about very briefly some of our like capstone projects from before. I know like Paola and Luke from last year are still like, participating in theirs and decreasing inpatient VTE. They're trying to decrease inpatient hypoglycemic events, but there have been several different like quality improvement projects that have been ongoing or completed through this process. And very briefly, we're going to touch on ours. The meaning of this giant graph is essentially that our veterans here at the James A. Haley VA, if you're inpatient and you're undergoing a moderate sedation procedure with IR, the cath lab, you're actually going to be like fasting for about 10.5 hours on average. That's what that purple line is. And this has been over the last couple of months. And so I'm working on trying to decrease pre-procedural NPO time because when we did a gap analysis, we actually realized that we're not meeting the standardized, anesthesia guidelines in terms of what we can do prior to moderate sedation for fasting. And so the ASA guidelines actually recommend 2 hours if you're on a clear liquid diet, 6 hours if you've had like milk, or a light like meal might be closer to 4. So we're trying to decrease that average in order to make sure that we're adherent with the guidelines.
And I'll just briefly touch about my capstone project, which kind of holds, some significance and importance to the medication optimization here at the James A. Haley. As we kind of know, treatment for heart failure with reduced ejection fraction, it encompasses really just what we call the 4 pillars of medical therapy. This being beta blockers, your ARNIs, your MRAs, and your SGLT2s. However, some of the medication optimization for these chronically reduced heart failure patients is a well-documented problem within the civil sector as well as our Veterans Affairs. There's insufficiencies or inefficiencies, rather, in medication optimization and are concerning due to the correlation between appropriate medical optimization and those leading to readmission rates and patient outcomes. So just a little bit of a background, just the CHAMP-HF registry, conducted a meta-analysis on revealing some of the significant lack of proper medication optimizations for heart failure. And incidentally, this meta-analysis found that we were only really optimized about 33% of eligible patients in the United States. Eligible patients had MRA therapies. In comparison to that, at our James A. Haley, our prescription practice is actually below average to 23.1%. So we're looking to optimize our medication prescription practice to possibly target goal of doubling that to 43%. So we've identified currently some root causes for this current problem, and we're now in the process of implementing solutions. And we're trying to find some sustainable solutions to improve our medication prescription practices.
All right. And so now the question is, how do we do more to continue improving our QI and patient safety education? So, in and of itself, we are a 3-hospital system. And in some cases with MedPeds, we're a 4-hospital system. So how do we increase our interdepartmental and interdisciplinary collaboration on QI projects? And that's across the board for USF. Assessment of QI and patient safety efforts across all affiliated sites, and try to increase our cross-site collaboration on projects. It's been increasing. This year has been amazing. Like, we've been working with TGH and stuff like that with trying to put together some of our efforts. But in and of itself, getting Moffitt and some of them involved as well, just to kind of have that collaboration. We also want to try to increase the number of trainees involved with projects and include them with QI and patient safety professional development, just so that way they can continue on and provide those efforts elsewhere at whatever institution they may go on to. Because that's the biggest help, is if you provide a basics in a framework for how to do all of these things and how to evaluate all these things, they're going to continue to work on those things in the future. With that, these are our references. And if you guys have any questions, please feel free to reach out. We're here, at least for the next couple months anyway. But there will be our next, CRQSs are Claire Stowers and Ruhi Vasavada. So they'll also be here. Yeah,
and then just shout out again, just taking this brief moment, shout out to Dr. Rice and Dr. Melser, they're just our quality improvement masters, and we're very thankful for their expertise and their mentorship during this year. Has been a great journey and a great process, and I just recommend it. It's been an incredible time. Thank you, everyone.
Thank you.